Hi students, I am Dr. Sakshi Arora Hans, National Faculty for Obs and Gynae, then author of Self-Assessment and Review of Obstetrics, Self-Assessment and Review of Gynaecology, and Self-Assessment and Review of ENT. And I am also the Medical Director for a nursing app, that is the Nursing Next app. So welcome to my YouTube channel, that is Dr. Sakshi Arora Hans, Obs and Gynae. Now, as I told you in my previous video, that in these videos I am not going to cover entire Obs and Gynae. If you want to watch my entire videos on Obs and Gynae, the PG and FMG students, they should download the Marrow app and they should subscribe to the Marrow videos. And if you are a nursing student and after listening to any of my lectures, you want to listen to all my lectures for midwifery, you should download the Nursing Next app and you should subscribe to it, right? Now, since I am going to cater to a large number of audience, the PG students, the PG entrance students, the FMG students and nursing students, at the beginning of each video, I'm going to tell that the video is important for which category of students. So today we are going to discuss 3 or 4 questions on a very important topic, and that is urinary fistula. This video is specifically meant for students who are going to give their NEET exam or who are going to give AIIMS exam or DNB exam, and also for the FMG students. So before I start my discussion on urinary fistulas, first let's have a look at a set of questions related to urinary fistulas. So question number 1 is, a patient presents to your office approximately 2 weeks after having a total vaginal hysterectomy with anterior colporrhaphy and Bursch procedure for uterine prolapse and SUI, right? She developed fever, burning, micturition and continuous urinary dribbling. She can also pass urine voluntarily, right? She denies any urgency or dysuria. Which of the following is the most likely explanation? Your options are option A, failure of procedure, option B, UTI, option C, vesicovaginal fistula, and option D, the ureterovaginal fistula, right? Now, this is first question. Second question is, arrange the following surgeries in ascending order of the risk of leading to genitourinary fistulas, right? Number 1 here is vaginal hysterectomy. Number 2 is the supracervical hysterectomy. Number 3, laparoscopic hysterectomy. And number 4, total abdominal hysterectomy. Now what you have to do is you have to arrange them in ascending order of the risk of leading to genitourinary fistulas, and your options are option A is 1, 2, 3 and 4, option B is 1, 2, 4 and 3, option C is 2, 1, 3 and 4, and option D is 2, 1, 4, 3, right? Then question number 3. True statements regarding genitourinary fistulas include option A, fistulas due to, so this is a multiple correct answer question, right? Option A, fistulas due to obstructed labor are generally large, that is 5 to 6 centimeters. Option B, VVF may present days to weeks after the initial inciting surgery, and those following hysterectomy, they occur typically after 1 to 3 weeks. Option C, most common cause of vesicouterine fistula is cesarean section. The option D is most common cause of ureterovaginal fistulas in developed countries is obstetrical trauma. And option C is any fistula more than 2 centimeters in size is a complicated fistula, right? So this was your question number 3 related to the fistulas. So question number 4, Youssef Syndrome consists of option A, amenorrhea, vaginal dribbling of urine and cyclical hematuria. Option B, amenorrhea, vaginal dribbling of urine and hematemesis. Option C, cyclical hematuria, hematemesis and vaginal dribbling of urine. Option D, amenorrhea, hematemesis and cyclical hematuria, right? Now, the last question is, postpartum VVF is best repaired after. Option A, 6 weeks, option B, 8 weeks, option C, 3 months, option D, 6 months, right? So these are 5 important questions which we are going to discuss, and so we are going to discuss a little bit about the urinary fistulas, right? Now, See, urinary fistulas, basically, they are of three kinds. Number one, there could be a fistula which is connecting the ureter to the vagina. Now, if a fistula is connecting ureter to vagina, which is shown in figure as number one, that is called as a ureterovaginal fistula. Number two, there could be a fistula which is connecting the bladder to the vagina, and then that's called as a vesicovaginal fistula, which is shown by number two in the image. Right? And number three is a fistula which connects the urethra to the vagina, and that is called as the ureterovaginal fistula, right? Which is shown as the number three in the figure as well. So these are basically the three kinds of urinary fistulas, right? Now, in all these three kinds of fistulas, the complaint of the patient is going to tell you which kind of fistula it is. For example, if a patient has got a ureterovaginal fistula, that means one of the ureter, for example, her left ureter is connected to vagina. So whatever urine her left ureter is bringing, via the fistula, it is going to come out from the vagina. So this patient is going to say that she has continuous dribbling of urine from her vagina. To understand this, let's have a look at the diagram which I showed you earlier. So have a look here. Now, this ureter is bringing urine, and this urine via the fistula is coming out from vagina. So patient will say that she has continuous dribbling of urine from her vagina. On the other hand, this ureter is normal, right? And whatever urine is being brought from this ureter, it is filling the bladder. Right? So this patient will also say that although she has continuous dribbling of urine from her vagina, she has normal urination also. Right? So if patient says that there is continuous dribbling of urine from vagina and normal urination, that means it's a ureterovaginal fistula. On the other hand, suppose there is a patient who has vesicovaginal fistula. Now, in case of vesicovaginal fistula, her bladder is connected to vagina. So, whatever urine is being brought, whether it is brought from the left ureter or whether it is brought from the right ureter, it is coming in the bladder. So whatever urine is being brought is finally coming in the bladder, and it is this bladder which via this fistula is connected to the vagina. So this patient will also say that she has continuous dribbling of urine from her vagina, but because her bladder is having a fistula, so her bladder will never get full, and this patient will say that there is continuous dribbling of urine from vagina and no normal urination. So this is a case of vesicovaginal fistula, right? Then suppose a patient has got a ureterovaginal fistula. Now, in case of a ureterovaginal fistula, you all know that urethra, it is always empty, right? It doesn't contain urine normally. In urethra, urine comes only at the time of urination. Now, because urethra is empty, so this patient will say that she doesn't have any continuous dribbling of urine, right? But only when she sits for urination, urine comes out normally also and from her vagina also. So make a table. On one side write the complaint and on another side write the type of fistula. So if patient says that there is no continuous dribbling of urine from vagina, but when patient sits for urination, urine comes out from vagina and urethra, that means it's a ureterovaginal fistula. Clear? Now, this is one way of distinguishing between these kinds of fistulas. The other way of distinguishing between these kinds of fistulas is the methylene blue 3 swab test. So now let's talk about this test. Now, what you do in methylene blue 3 swab test? In a methylene blue 3 swab test, you are going to take 3 cotton swabs. One of them you are going to place it high in vagina so that it roughly corresponds to the level of the ureterovaginal fistula. A second one you are going to keep in the middle of vagina so that roughly it corresponds to the level of a vesicovaginal fistula. And the third one you are going to keep it lower down in vagina so that it corresponds to a ureterovaginal fistula. That is why a ureterovaginal fistula is also called as a high vaginal fistula. A vesicovaginal fistula is also called as a mid-vaginal fistula, and a urethrovaginal fistula is also called as a low vaginal fistula. Right now, in methylene blue 3 swab test, after placing these 3 cotton swabs, you are going to take a Foley's catheter, and with the help of this Foley's catheter, you are going to put approximately 200 ml of methylene blue dye in the bladder as well as in the urethra. Right, and then you are going to remove the Foley's catheter, and you are going to tell your patient to walk for 10 to 15 minutes, and after that you are going to take out the cotton plugs one by one, and you are going to observe the result. Right, so let's see what kind of observation we are going to get in different kind of fistulas. Now, first of all, suppose if it is a ureterovaginal fistula, what you have to understand is that you have put the dye in the bladder and you have put the dye in the urethra. You have not put the dye in the kidney, you have not put the dye in the ureter, right? And ureter is bringing urine from the kidney. That urine is absolutely clear urine, right? So look at this image again. Ureter is bringing clear urine from the kidney. So if patient has a ureterovaginal fistula, via the fistula, this clear urine is going to wet the uppermost cotton swab. Right? So if you are getting that the uppermost cotton swab is wet with urine, but it doesn't have any dye, that means it's a ureterovaginal fistula. So what I want you to do is, you are going to make a table. On one side you are going to write observation, and on the other side you are going to write interpretation. So if your observation is that the uppermost cotton swab is wet with urine but it doesn't have any blue color, then the interpretation becomes a ureterovaginal fistula. Now, in the bladder you had put a blue color dye, that is the methylene blue dye, right? So I had put methylene blue dye in the bladder. Now suppose patient has got a vesicovaginal fistula. In that case, what is going to happen is this blue colored dye and urine via this fistula is going to make the middle cotton swab wet, and it will be blue in color. Right? Now, ideal situation is that the question should say that the middle and the lowermost cotton swab are blue in color and they are wet. But mostly the question will not say the lower one. It will say the middle cotton swab is blue in color and is wet. Right? And diagnose the type of fistula. So you know that this kind of fistula is a vesicovaginal fistula. So your second observation is you should write middle and in brackets write plus lower cotton swab is wet with urine and blue in color, then it means it's a vesicovaginal fistula. Whereas in case of a ureterovaginal fistula, via the fistula, the blue colored dye is going to come and it is going to wet only the lowermost cotton swab. Right? So if the question says that only the lowermost cotton swab is getting wet and is blue in color, that indicates it's a ureterovaginal fistula. Right? So this is how you can distinguish between the different kinds of fistulas. Clear? Now there are three very important questions which you should be remembering about the investigations of choices in a fistula. The first important question is, which is the best investigation in a patient for VVF? Now, the best investigation for VVF is cystoscopy. You are not going to say it's a methylene blue 3 swab test. Now, why cystoscopy is the investigation of choice in a patient of VVF? That is because cystoscopy will help you in determining the exact site of the fistula, the exact size of the fistula, and the number of the fistulas, right? Next important question is, what is the best investigation to detect ureteric fistula in a patient of VVF? Now, this is something which is called as a concomitant fistula. A concomitant fistula means that a patient of VVF is also having a ureteric fistula. So, in all patients of VVF, you have to rule out ureteric fistulas because a concomitant fistula is present in 10 to 15% cases. And the investigation of choice to do that is a contrast enhanced CT. Right? You will do a contrast enhanced CT in order to know whether there is ureteric involvement or not. Now, suppose if contrast enhanced CT is not given in the options, then the second best answer here will be IVP, intravenous pyelography. Now, question number 3. What is the best method to collect urine in a patient of VVF? The best method to collect urine in a patient of VVF is by suprapubic catheterization. Right? So this is in general what I wanted you to know about fistulas. Now I want to talk about specifically about the vesicovaginal fistulas, right? Now, vesicovaginal fistula is the most common urinary fistula. That is first thing which you have to remember. The second thing which you have to remember about a VVF is that what is the most common cause of VVF in a developed country. Now, in a developed country, the most common cause of VVF is surgery, and that is hysterectomy. Number 3 question is, what is the most common cause of VVF in a developing country? In a developing country, the most common cause of VVS is obstructed labor. That means it's an obstetrical cause, right? Then, next question which they ask you is that amongst the various routes by which you do hysterectomy, with which route the chances of having VVF are highest? Now, highest chances of VVF are when you are doing a laparoscopic hysterectomy. That has got the highest chances of leading to a VVF. Second highest chances are when you are doing open hysterectomy. That means when you are doing an abdominal hysterectomy. Third common chance is with vaginal hysterectomy, and the least common chance is if you are doing a subtotal hysterectomy. In other words, which is also called as a supracervical hysterectomy, right? So in decreasing order, the order is the highest chances are with laparoscopic hysterectomy, number 1. Number 2, it's with total hysterectomy. Number 3 is with a vaginal hysterectomy. And number 4, the least common chances or the least chances are with a supracervical hysterectomy. Right? Now, if they ask you that apart from obstructed labor and apart from surgery, what are the other causes of VVF? Now, this can be a viva question, so very important for undergraduate students. The other causes of VVF, they can be malignancy, number 1. Then it could be post-radiation. It can lead to VVF. Number 3, infections like tuberculosis, schistosomiasis can lead to VVF. Number 4, inflammations can lead to VVF. And number 5, inflammatory bowel disease can lead to VVF, right? Then you all know that how a patient of VVF is going to present to you. Just now I told you that in a patient of VVF will say that she has continuous dribbling of urine from her bladder, but there is no normal urination. And on methylene blue 3 swab test, you are going to get that the middle cotton swab becomes blue in color and is wet. The investigation of choice for VVF, as I told you just now, is cystoscopy. Now, what is the management of a VVF? So the management for VVF always is a surgical repair. The first important thing is what is the time for repair? Now, the time for repair if suppose the fistula is detected within 24 to 48 hours of surgery, in that case, you have to repair the fistula immediately, right? But if the fistula is detected after 48 hours or if the fistula was due to obstructed labor, in that case, you have to repair the fistula after 6 weeks because the tissue is very fragile, right? After obstructed labor also, the tissue is very, very fragile. And in suppose infection has happened, then also the tissue is very fragile. And in that fragile tissue, I do not want to do any surgery, right? So I'm going to postpone my surgery for 6 weeks in case of obstructed labor, or suppose the fistula was detected after 24 to 48 hours of surgery. right? Now, what is the technique of repair? Now, as far as the technique of repair is concerned, you have to understand basically two techniques, right? Number one is Sims saucerization technique, and number two is Latsko technique, right? So let's have a look at the surgery for VVF, and that is Sims saucerization. Now, as you can see in this image here, I have the bladder, right? And this bladder over here is connected to vagina with the help of a fistula. Now, in a bladder, you know that from inside to outside, the layers of the bladder are bladder mucosa, then you have the muscle layer, and then you have the serosa. Right? So what you do in Sims saucerization is you have to block this passage. So I am going to block this passage from the bladder side and I'm going to block the passage from the vaginal side. So I am going to give stitches, circumferential stitches on the bladder mucosa first. Then I am going to give a circumferential stitch on the bladder serosa, right? And then a third circumferential stitch will be over the vaginal epithelium, right? So from inside to outside, you are putting 3 layers of stitches. The innermost layer is on the bladder mucosa, then the middle layer will be of the bladder serosa, and then there will be the vaginal epithelium. Why it is called as Sims saucerization is because suppose you have a cup and saucer stand, and when you have to place, have you seen that how you place the saucers in that stand? You know, you place them one after the other, right? So like you place your saucers in a stand, here also you will get 3 circumferential incisions. From inside to outside, they will be on the bladder mucosa, on the bladder serosa, and on the vaginal epithelium, right? Now, what you have to remember about Sims saucerization is that you are going to do it under general anesthesia, number 1. Number 2, the best position of the patient for doing this surgery is the knee chest position. Number 3, this kind of surgery is done for fixed fistulas, right? So after radiation or after malignancy, if there is a fixed fistula, then Sims saucerization is done. But then in comparison to the new technique, which I'm going to tell you, Latsko's technique, the Sims saucerization is an outdated technique. Clear? So this was one way of repairing the vesico-vaginal fistula. The second way, or the most recent way of repairing a vesico-vaginal fistula, is by doing a Latsko technique. So I'm writing the spelling here. Please copy it. Latzko. Latsko technique. Now, what do you do in a Latsko technique? In a Latsko technique, first what you're going to do is you are going to make the fistula visible to you, right? Now, once the fistula is visible to you, you are going to give a circumferential incision around the fistula, which in this image you can see is the green colored incision which I have given. The dark blue or the bluish blackish color is the fistula. So over here, this is the fistula tract. This over here is the tract of the fistula, the opening of the fistula. And around the opening of the fistula on the vaginal epithelium, I am going to give a circumferential incision 1 to 2 centimeters above it, right? Now what I'm going to do is I am going to cut the vaginal epithelium. Right? So this over here, I am cutting the vaginal epithelium by giving 4 incisions. I am going to cut the vaginal epithelium. Why am I cutting the epithelium is because epitheliums, they are always a hindrance in the healing of the fistulas, right? So I have now cut the excessive vaginal epithelium around the fistula. Now I am going to remove the fistula, the tract of the fistula, either partially or completely. Why am I saying either partially or completely? Because if you are unable to remove it completely from the bladder end, so suppose if the mouth of the fistula from the bladder end is very large, do not try to remove it completely from there because you might injure the urethral orifice there. right? That is why I'm saying as much as possible, either partially or completely, you are going to remove the fistulous tract. And now I am going to close it from the bladder end also, and I'm going to close it from the vaginal end also. So I am going to approximate the bladder mucosa right first. Then I'm going to put stitches on the muscles of the bladder. So that means bladder, I'm closing it in 2 layers. And then I am going to close this fistulous tract from the vaginal end also. Right? So this is what you do in a Latsko technique. Now suppose the fistula which you are repairing by the Latsko technique is high up in the vagina. In that case, what you will have to do is you will have to approximate the anterior and the posterior wall of vagina also. And that means that will result in shortening of vagina, and that is exactly what you do in colpoclysis also, in partial colpoclysis. So Latsko technique will be incorporating partial colpoclysis, that is, you will be shortening the vagina just in case the fistula is located high up in vagina. Right? Another very important point which you should note here is that once you have closed the fistula from the bladder end, and you are going to close the fistula from the bladder end first, and that too you are going to approximate, first thing what you're going to approximate is the bladder mucosa. So once you have approximated the bladder mucosa, you should test that these sutures which you have put are watertight. And how you're going to do that? You are going to instill 200 ml of normal saline in the bladder, and you are going to see that there is no leakage now, right? And then you are going to proceed to the muscle layer of the bladder, and then you are going to put stitches on the vaginal epithelium, right? So in Latsko technique, the anesthesia which you are going to give is general anesthesia. You are going to do it under general anesthesia. The position which the patient should be for Latsko technique is a dorsal lithotomy position. Mostly Latsko technique is done for mobile fistulas. In other words, any fistula which is happening after surgery, right? And it's the most commonly used technique. One other technique which earlier days was used to repair a vesicovaginal fistula, and so many times this technique has been asked that this is a technique for which surgery, right? For repair of what problem? And that technique is Chaser-Moyer technique. So remember that Chaser-Moyer technique is done for repairing vesicovaginal fistulas. FMG students, this question has come twice to you, that Chaser-Moyer surgery is done in case of. So remember, it's done in case of a vesicovaginal fistula, right? Now, for all the PG entrance students and for all the undergraduate students, there are certain principles which have to be kept in mind no matter what technique you are adopting for repairing a vesicovaginal fistula. Number one principle which you have to keep in mind is that always the tissue should be non-infected and non-inflamed. And this is the reason why I told you that if a fistula is detected after 24 to 48 hours of any surgery, then you have to wait for 6 weeks to repair it. Number two, whenever you are approximating any tissue, then there shouldn't be any excessive tension there during approximation, right? Number three, the bladder repair has to be watertight, right? And how to check that it is watertight, I told you just now. And number four, after surgery, you have to do a continuous bladder drainage with Foley's catheterization for 10 to 14 days. You have to do that. Right? So this is what you have to do in the principles which you have to remember in case of fistula repair. Clear? Now, a few very important points, other important points which I want you to remember are that obstetrical fistulas. Now, whenever any fistula is caused due to any obstetrical injury, it is generally large and it is 5 to 6 centimeters in size. That's one thing which you have to remember. Second very important point which you have to remember is that if any fistula is more than 3 centimeters in size, that's called as a complicated fistula. right? Less than 3 centimeters, it's a simple fistula. Similarly, if fistula is because of any radiation, right, then also, or if it is happening after malignancy, then also it's a complicated fistula, right? Then surgical fistulas, any fistula which is happening because of surgery, they are generally small, 1 to 2 millimeters, and they are located at the vaginal apex, right? So this is what I wanted all of you to remember about the vesicovaginal fistula. Now, about urethrovaginal fistulas, again you have to remember that the most common cause of a urethrovaginal fistula in a developing country again is obstetrical trauma. That obstetrical trauma can be in terms of obstructed labor, or it can be due to forceps delivery, right? The most common cause of urethrovaginal fistula in developed countries is again surgery, and surgeries like anterior colporrhaphy and urethral diverticulectomy, right? Now, again, in urethrovaginal fistula, you know that a patient is going to say that she doesn't have any continuous dribbling of urine from vagina, but when she sits for urination, urine comes out from her vagina as well as from her urethra. And when you will do a methylene blue 3 cotton swab test, what you're going to get? You are going to get that only the lowermost cotton swab was wet and was blue in color, right? This is what you have to remember about the urethrovaginal fistula. Now, about the ureterovaginal fistula. About the ureterovaginal fistula, you have to remember is that what is the most common surgery which can lead to ureteric injury. Now, the most common surgery which leads to ureteric injury is a hysterectomy. And which hysterectomy? It's a simple hysterectomy. A simple hysterectomy is also called as a total abdominal hysterectomy. And why I'm saying that it is the most common surgery which leads to ureteric injury? Because this is the most common kind of hysterectomy which is done, right? Now, suppose this question is asked, and actually this question has been asked in AIIMS twice. Maximum risk of injuring the ureter is with which hysterectomy? Now, maximum risk of injuring the ureter is with AIIMS hysterectomy. You are not going to say it is with radical hysterectomy. Why? Because in a radical hysterectomy, you have to remove the entire cardinal ligament. Right? So first understand here, this over here is your uterus, right? And this over here is the pelvic wall. Now, this ligament which is over here extending like this from the sides of the uterus to the pelvic wall is the cardinal ligament, right? And a very important structure passes here like this, and this is the ureter, right? Now, what happens in a radical hysterectomy? In a radical hysterectomy, you have to remove the entire cardinal ligament. So when I have to remove the entire cardinal ligament, I'm going to cut from here and I'm going to cut the cardinal ligament from here, right? But in case of AIIMS hysterectomy, which is also called as a modified radical hysterectomy, you have to remove the medial half of the cardinal ligament. Now, imagine if you have to remove the medial half of the cardinal ligament, you are going to remove the cardinal ligament from here, right? And when you are removing the cardinal ligament from here, this is the place where ureter is present. And that is why maximum risk of injuring the ureter is with AIIMS hysterectomy. But the most common hysterectomy which leads to ureteric injury is a simple hysterectomy, because simple hysterectomy, that is total abdominal hysterectomy, because that's the most common hysterectomy which is done. The third question which we did in vesicovaginal fistula was that which is the most common route which leads to a genitourinary fistula. The most common route is laparoscopic hysterectomy. Right? So these are three questions, very, very important. And the other question which is very important is in case of a ureterovaginal fistula, and we are talking about the ureteric injuries, is that what is the most common site for ureteric injury? during hysterectomy. Now, the most common site for ureteric injury during hysterectomy is where the ureter is directly crossed by the uterine artery. That is the most common site, and ureter is crossed by the uterine artery 2 centimeters lateral to the internal os, right? And this area where the ureter is crossed by the uterine artery, that is called as the water under bridge. So I want you to look at this diagram over here. So over here, this yellow color is the ureter, right? Can you see this? It's ureter. And this over here, red color, which now I'm going to make black. This red color is the uterine artery, right? So you can see 2 centimeters lateral to internal os, the ureter is directly crossed by the uterine artery, and this area is called as water under bridge, and this is the most common site for ureteric injury during hysterectomy, right? So let's have a closer look at one more figure. So over here, in this figure, it's very, very clear. So this over here, which yellow color, which I am now going to make it orange. This over here is the ureter, right? And this was our uterine artery, right? So this area where the ureter is directly being crossed by the uterine artery, that is 2 centimeters lateral to internal os, and that is called as water under bridge, and this is the most common site for ureteric injury. Second most common site for ureteric injury is the pelvic brim, right? So these are questions which are related to the ureter, right? And ureterovaginal fistula. In a ureterovaginal fistula, the patient is going to complain of continuous dribbling of urine from her vagina, and there will be normal urination. On a methylene blue 3 swab test, you are going to get that the uppermost cotton swab is wet, but it is unstained with urine. But it is unstained with any dye. It's wet with urine, but it doesn't have any blue color. It's unstained with the methylene blue dye. Why? Because you were putting methylene blue dye in the bladder. Now suppose instead of methylene blue dye, you give patient orally pyridium dye, right? Now this pyridium dye or pyridine, when you are giving it orally, it will make the urine orange in color, right? So in that case, what is going to happen is that this orange colored urine will come via the ureter, and through the tract, through the fistula, it is going to make the uppermost cotton swab orange in color, right? So this is if you have given the dye orally. And which dye orally? The pyridine dye. If you have given pyridine tablet, if you have given to the patient orally, in that case, the uppermost cotton swab will become orange in color, right? So this was what you had to know about the fistulas, urinary fistulas. There is one more urinary fistula which you have to know, and that is suppose there is a fistula which is connecting the bladder to the uterus, and that fistula is called as a vesicouterine fistula. Now, in case of a vesicouterine fistula, so over here we have the bladder, and over here is the uterus, right? So suppose you have a fistula which is connecting the bladder to the uterus. Now, because this fistula is connecting the bladder to the uterus, and uterus is at a higher level than the bladder, so obviously in this case, patient will not have any dribbling of urine. She will not complain of that, because urine, it cannot go up, right? It's not going to happen that urine is going to go up and then it is going to come out from the uterus. No, right? So patient will not complain of any dribbling, continuous dribbling of urine. What she's going to say is that at the time of menstruation, her menstrual blood will come inside the bladder, and that will lead to cyclical hematuria, right? So patient will say that every time during menstruation she has hematuria. This is the basic complaint in a vesicouterine fistula, and cyclical hematuria is called as menorrhagia, right? So cyclical hematuria is seen in vesicouterine fistula. And what other condition can you get a cyclical hematuria? There is only one more condition where you can get a cyclical hematuria, and that is endometriosis of the bladder, right? So these are the only two conditions where you get cyclical hematuria. Another very important question which you have to remember about a vesicouterine fistula is that the most common cause of a vesicouterine fistula is cesarean section. And that is why, because the incidence of cesarean sections is increasing these days, that is why the incidence of vesicouterine fistulas is also increasing these days, right? And another last thing which I want you to remember is something which is called as Youssef Syndrome, Youssef, Youssef Syndrome, right? Now, what is Youssef Syndrome? Youssef Syndrome is a combination of, number one, amenorrhea. So patient will have amenorrhea, secondary amenorrhea. She will be having cyclical hematuria, and there will be a genitourinary fistula. Which kind of genitourinary fistula? A vesicouterine fistula. So whenever there is a triad of amenorrhea plus cyclical hematuria plus a vesicouterine fistula, that is called as a Youssef syndrome, right? Okay, so now before I end this topic, we are going to discuss the questions which I had shown you in the beginning of the video, right? So in the beginning of the video, I showed you question number 1, and that question number 1 was, a patient presents to your office approximately 2 weeks after having, so here this line 2 weeks is important, after having a total vaginal hysterectomy with anterior colporrhaphy and Bursch procedure. Now, first tell me, what is this Bursch procedure used for? See, Bursch procedure is for stress urinary incontinence, right? So it was for uterine prolapse. So total vaginal hysterectomy with anterior colporrhaphy was done for uterine prolapse, and Bursch procedure, as I told you just now, it's a surgery for SUI, the stress urinary incontinence. She developed fever, burning micturition, and continuous urinary dribbling. She can also pass urine voluntarily. So your patient has got fever, burning micturition, continuous urinary dribbling, and she can pass urine voluntarily. All these are happening 2 weeks after the surgery. She denies any urgency or dysuria, right? Which of the following is the most likely explanation? Now, students, what I want you to understand here is not only always is the answer important, it's also important that why not the other options, right? If you have this kind of an approach, then that's the best in the long run, because then you will have a complete understanding. So don't only go after the correct answer, always try to understand why not the other options. So here, this is what our approach is going to be. So let's see option A, failure of procedure. Now tell me, do you think failure of procedure is the correct answer? Now first understand failure of which procedure. So here they are talking about failure of Bursch procedure, because when there will be a failure of Bursch procedure, then only the patient will complain of dribbling of urine, right? Now, if this is a failure of Bursch procedure, patient should complain of stress urinary incontinence. She shouldn't be saying continuous urinary dribbling, right? Continuous urinary dribbling is not seen in SUI. What is SUI? SUI is a condition in which a patient passes urine involuntarily when her intra-abdominal pressure increases. For example, when she coughs, when she laughs, then, right? So that kind of a presentation would have indicated that yes, this is a failure of procedure, right? So failure of procedure is not correct. UTI. Okay. Now fever and burning micturition, they go in favor of UTI, but the features or the complaints which are not favoring UTI are, patient is complaining of continuous urinary dribbling. In UTI, patient will not complain of continuous urinary dribbling, number 1. Number 2, here the question is specifically telling you she denies any urgency or dysuria, and obviously if there is UTI, patient will have dysuria, she will have an urgency also, right? So again, UTI ruled out. So this means that this patient has developed a fistula because of hysterectomy, because her total abdominal hysterectomy and anterior colporrhaphy were done, and these are the one of the two very important causes of fistulas. Right now, so option C and option D both are fistulas. Now we have to decide whether patient has developed a VVF or whether patient has developed a ureterovaginal fistula. Now, in the question is specifically telling you that this patient has continuous urinary dribbling and she can pass urine voluntarily. So, if patient can pass urine voluntarily, that means it's a ureterovaginal fistula. In a vesicovaginal fistula, patient will not be able to pass urine voluntarily because her bladder will never get full. Right? So, answer to question number 1 is a ureterovaginal fistula. Clear? Now, let's go to question number 2. Question number 2 says, arrange the following surgeries in ascending order of the risk of leading to genitourinary fistulas. Right? So, you have to tell from least to maximum. You have to tell which surgery has the highest, least chances, and then which surgery has the maximum chances. So amongst the options given to you, I told you that the least chances are always with a supracervical hysterectomy, that is a subtotal hysterectomy. So least chances are with option 2. Then it is with vaginal hysterectomy. Right, then it is with total abdominal hysterectomy, and maximum chances are with laparoscopic hysterectomy. So you have to look for an option which says 2, 1, 4, 3, and that option is option D. So always read your question very carefully, whether they are asking you ascending order or whether they are asking you descending order, right? These are about the routes of hysterectomy. If they would have asked you 2 questions, which hysterectomy has highest risk, you know it's a AIIMS hysterectomy, and which is the most common hysterectomy leading to a urinary fistula or a ureteric injury. So most common was total abdominal hysterectomy or simple hysterectomy, right? Okay, then question number 3. 2 statements regarding genitourinary fistulas. Okay, so this was a multiple correct answer question. Option A, fistulas due to obstructed labor are generally large, 5 to 6 centimeters. Yes. So obstetrical fistulas, as I told you during the lecture also, they are generally large and they are 5 to 6 centimeters. So this is a correct statement. Option B, VVF may present days to weeks after initial inciting surgery, and those following hysterectomy that typically occur after 1 to 3 weeks. Very, very important. This line you have to remember, that most of the time VVF is going to present 1 to 3 weeks after hysterectomy. So now in question number 1 also, you could see here the question was specifically telling you that the patient is presenting with urinary dribbling 2 weeks after surgery. So most of the time, if the fistulas are because of hysterectomy, whether it is a vesicovaginal fistula or whether it is a ureterovaginal fistula, most of the times they are going to present to you 1 to 3 weeks after the surgery. Then most common cause of vesicouterine fistula is cesarean section. Again, this is a true statement. I told you that the most common cause of a vesicouterine fistula is cesarean section, right? So here option A, B, C are correct. Let's go and look at option D and E. Option D says most common cause of ureterovaginal fistula in a developed country is obstetric trauma. Okay, so in developed country, it is not obstetric trauma. In developed countries, it is hysterectomy. That means it is due to surgery. In developing countries, it is due to obstetric trauma like an obstructed labor or due to a difficult forceps delivery. A difficult forceps delivery can lead to a ureterovaginal fistula, right? So this option over here is incorrect. Option E, any fistula which is more than 2 centimeters in size is a complicated fistula. No. Any fistula which is more than 3 centimeters in size is a complicated fistula, right? A fistula which is less than 3 centimeters is a simple fistula. Any fistula which is due to malignancy or which is happening post-radiation is also a complicated fistula, right? Okay, so that is your option E is also incorrect. So in question number 3, your option A, B and C were the true statements. Clear? Then question number 4. Youssef syndrome consists of. Now, Youssef syndrome, I told you Youssef syndrome means that there is a vesico-uterine fistula, and because you have vesico-uterine fistula, it leads to cyclical hematuria. So you will get a triad of vesico-uterine fistula plus a cyclical hematuria, plus you get amenorrhea in Youssef syndrome. Right? And I also told you that most of the times in a vesico-uterine fistula, vaginal dribbling of urine doesn't happen. That's the most common thing seen in a vesico-uterine fistula. But sometimes a vesico-uterine fistula is placed at a lower level. And when a vesico-uterine fistula will be placed at a lower level, you will get vaginal dribbling of urine. Right? So Youssef syndrome is, number 1, you will have a cyclical hematuria. Number 2, you will have amenorrhea. And number 3, either the option is going to say that there is a vesico-uterine fistula, or the option may say vaginal dribbling of urine, like in this question. Right? So here your answer is option A is saying amenorrhea, vaginal dribbling of urine and cyclical hematuria. Yes, that's the correct option. But let's see the other options also. Amenorrhea, vaginal dribbling of urine and hematemesis? No. Cyclical hematuria, hematemesis and vaginal dribbling of urine? No, hematemesis is not seen. Amenorrhea, hematemesis and cyclical hematuria? Amenorrhea is seen, cyclical hematuria is seen, but hematemesis is not seen. Right? So again here the correct answer here is option A. Clear? Then question number 5. Postpartum VVF is best repaired after. So a postpartum VVF, as I told you in the lecture also, it's best repaired after 6 weeks. So the answer here is option A. Clear? So I hope you've enjoyed today's lecture on urinary fistulas and you have understood. Now you can answer all questions on urinary fistulas. If that is the case, please do not forget to like, subscribe and share my video. And also do not forget to turn on the post notification so that you get updated about all my latest videos. Stay home, stay safe, keep studying. All the best.